ever thought about how sometimes, a simple fever isn't just a simple fever? How it could actually be hiding something much more serious, escalating really fast? Well, today, that's exactly the kind of challenge we're diving into. Dengue fever. It's a disease that affects millions of people across the globe, and getting a handle on its complexities is, well, it's a shortcut to understanding a really critical global health issue. Our mission here on this deep dive is basically to cut through all the dense medical information, the jargon, and pull out the absolute must know pieces from our sources. We'll look at how dengue is spotted, how it's carefully classified, the very precise ways it's managed, and maybe most importantly, when it becomes an emergency needing urgent medical help. Think of it as us getting under the hood of the strategies doctors use.
Yeah, and what's really striking, and you see this consistently in the source materials, is just how detailed the medical guidelines are. They draw these really clear lines between the different stages of dengue. It's not a static thing, it progresses. And understanding that progression, those shifts, is just so vital, especially when you consider how common dengue is in, well, huge parts of the world. These guidelines are more than just advice. They're a specific roadmap.
Right, a roadmap. That's a good way to put it. And that's the journey we want to take you on. We'll start at the very beginning, those first symptoms that make a doctor think, could this be dengue?
Mm.
Things like feeling really nauseous, maybe vomiting, getting a specific kind of rash, muscle aches, myalgia headaches, of course, and that weird pain behind the eyes.
Retroorbital pain, yeah.
Exactly. Retroorbital pain, plus joint pain, arthralgia, and sometimes even small signs of bleeding, these hemorrhagic manifestations. And then we'll move into the really critical part, the warning signs. These are the big red flags. Things like sudden bad stomach pain, vomiting that just won't stop, or fluid building up weirdly in the body. That's when doctors know things are getting serious.
Hmm.
We'll also touch on the key diagnostic tools like the NS1 antigen test and how doctors track blood counts, platelets, and PCV specifically. And then the treatment itself varies step-by-step protocols, especially for shock, managing fluids, blood products.
It's incredibly precise.
And finally, the strict rules for when someone is actually safe to go home. It sounds complex, and it is, but it's a really structured workflow.
And linking that back, the reason for all this detail really hits home when you think about it. These protocols aren't just theoretical. They are designed explicitly to help doctors make incredibly fast, potentially life-saving decisions when the pressure is on, and a patient's condition could literally turn on a dime. Which brings up a key point. How do these detailed steps actually help clinical teams navigate such a fast-moving disease?
Exactly. That's the core question, isn't it? So let's put ourselves in a clinician's shoes for a moment. When do those first alarm bells go off? What makes them suspect dengue rather than, say, just the flu or some other virus? Our sources lay out a pretty clear picture. It usually starts with a fever, obviously, but then it's the combination, the fever, plus at least two of those other specific symptoms we just listed. So again, that's the nausea, vomiting, the rash, muscle pain, myalgia headache, that pain behind the eyes, joint pain.
Or any minor bleeding signs like petechiae, those tiny red spots.
Right, those hemorrhagic signs. And crucially, the person either lives in or has recently traveled to a place where dengue is, known to circulate. That whole combination is the trigger. That's what makes a doctor pause and think, okay, dengue is on the table here.
Precisely. And once that suspicion is there, the very next step is assessment and, crucially, classification. This isn't just about putting a label on it. It's about gauging the severity right away. The guidelines immediately push you to sort it into one of three buckets: dengue without warning signs, dengue with warning signs, and the most serious category, severe dengue.
This initial sorting is absolutely fundamental because it basically dictates everything that follows the management plan.
And those warning signs, you mentioned the sources, are really emphatic about these, aren't they? They're not subtle hints. They are explicit triggers for getting that patient to a higher level of care, maybe hospital admission.
Absolute. Game changers, like you said. We're talking about things like really bad abdominal pain or tenderness that seems to be getting worse, not better, persistent vomiting, like they just can't keep anything down at all. And then this clinical fluid accumulation, which sounds technical, but it means fluid showing up where it shouldn't, maybe signs of it around the lungs, that's pleural effusion, or the abdomen ascites.
And you also have to look for any bleeding from mucosal surfaces. So that could be nosebleeds, epistaxis, or bleeding gums. Even things like melena, which is that dark tarry stool suggesting internal bleeding higher up. The guidelines also flag liver enlargement, specifically more than 2 centimeters below the rib cage, and any indication of shock, even if it seems mild at first.
Like what kind of signs for shock?
Well, maybe a pulse that's fast but feels weak, or a really narrow pulse pressure. The difference between the top systolic and bottom diastolic blood pressure numbers gets very small. Or even just cold, clammy skin. That points to poor circulation. All immediate alarms.
Okay, so if those warning signs are like a flashing yellow light, signaling caution and closer monitoring, what turns the light red? What defines severe dengue?
Severe dengue is the critical end of the spectrum. It happens when the disease starts seriously affecting vital organs. Our sources define it mainly by three things. One is that fluid accumulation becoming so bad it causes respiratory distress. The patient is physically struggling to breathe because fluid is interfering with their lungs. Two is severe bleeding that's difficult to control. And three is organ impairment, things like severe liver damage, kidney failure, or even impaired consciousness, showing the brain might be affected. These are true medical emergencies requiring intensive care immediately.
Right, intensive care. So, okay, the clinician has assessed the patient, they've classified the severity. What tests do they rely on? What are the key lab investigations needed to confirm things and really guide the treatment path?
This is where the lab work becomes absolutely essential. The source materials really zero in on several key blood tests. You need a baseline hemoglobin, check the white blood cells with the total and differential count. But the real focus is often on platelets, those clotting cells, and the packed cell volume, or PCV, sometimes called hematocrit,
Why PCV specifically?
because it tells you about fluid shifts. If the PCV starts rising significantly, it suggests plasma is leaking out of the blood vessels, which is a hallmark of worsening dengue. Conversely, if it starts dropping later, especially without clinical improvement, it might indicate internal bleeding.
Okay, makes sense.
They also mentioned the tourniquet test, though its use can vary. It checks for capillary fragility, another sign of dengue's effects. But for actually diagnosing it, particularly early on, the NS1 antigen test, usually done with an ELISA method, is highlighted as being super important.
NS1.
Yeah, it detects a specific protein from the dengue virus itself. The beauty is it can often be positive even before the body has had time to produce antibodies. So it gives you a much earlier confirmation.
Ah, so it helps differentiate dengue from just any other fever much faster.
Exactly, which is incredibly valuable for starting the right management quickly.
It definitely sounds like NS1 is a huge help for that early ID. So let's talk treatment. How does the approach change based on that classification? No warning signs, severe.
It's very, very structured, almost like following a decision tree. For that first category, dengue without warning signs, the management is mostly supportive care, often done at home. This mainly means rest, plenty of fluids orally, and using paracetamol acetaminophen for fever or pain. And here's a really critical point our sources stress. Absolutely no NSAIDs.
Like ibuprofen or aspirin.
Correct. Avoid them completely. The reason is that NSAIDs can interfere with platelet function and increase the risk of bleeding, which is already a potential complication in dengue, making a bad situation potentially much worse. It's a subtle point, but so important.
That is a vital detail. A lot of people might reach for ibuprofen automatically for fever. So, for mild dengue, it's about managing symptoms, staying hydrated, and watching carefully. But what happens if those warning signs do pop up? Or worse, if a patient actually develops shock? That's where things escalate dramatically, right?
Dramatically and rapidly, yes.
Yeah.
The moment shock is suspected or confirmed, the entire management strategy shifts gear into a much more aggressive resuscitation mode. The guidelines lay out very specific, urgent steps for both compensated shock, where the body's still trying to keep blood pressure up, but you see signs like fast breathing, rapid heart rate, and hypotensive shock, where the blood pressure has already fallen dangerously low. This is really crunch time. Immediate action is critical.
And this is where that precise fluid management comes in that you mentioned earlier.
Exactly. It's incredibly specific. For any patient in shock, compensated, or hypotensive, the very first move is a rapid, large intravenous fluid bolus. We're talking about 20 milliliters for every kilogram of the patient's body weight.
Okay, 20 milliliters per kilogram of what kind of fluid?
Either a crystalloid solution, like normal saline or Ringer's lactate, or a colloid solution. Colloids have larger molecules. They tend to stay in the bloodstream a bit longer.
And how fast do they give this?
Very fast, over just 15 minutes. And then immediately after that bolus finishes, you reassess the patient. Check their vital signs, their urine output, their mental status. How did they respond?
Okay, 15 minutes is quick. So what if they improve after that big initial push of fluid?
If they show signs of improvement, pulse slows down, blood pressure stabilizes, they seem more alert. You don't just stop the fluids, you start carefully reducing the infusion rate. And again, it's not arbitrary. The guidelines provide a very precise step-down protocol. You might go from that initial bolus to, say, 10 millinella curiae for an hour or two, then down to 5-7 millinella curiae, then 3-5, then even lower, typically stopping IV fluids altogether on the 48-hour mark if they remain stable.
Wow, that's really fine-tuning it.
It is. It's a real balancing act. Our sources emphasize this. You need to restore volume quickly to treat the shock, but then you have to back off carefully to avoid fluid overload, which can cause its own serious problems, like fluid in the lungs. That gradual reduction is absolutely key.
It sounds like constant monitoring and adjustment. But what if? What if that first big fluid bolus doesn't work? What if the patient doesn't improve? What do the protocols say then?
That's another critical decision point. If there's no improvement after that initial resuscitation, clinicians are guided to think about why. Could there be something else going on? Maybe significant hidden bleeding, or perhaps severe metabolic acidosis, or even underlying heart problems affecting the response. You have to investigate and treat those specific issues. Now, if the PCV, that packed cell volume, actually goes up despite the fluid, but the patient still isn't getting better clinically, the guidelines suggest considering another bolus, potentially with a colloid this time. That rising PCV suggests the plasma leakage is ongoing and severe.
Okay. And what if the opposite happens? What if the PCV goes down, but the patient still isn't improving?
That's a big red flag for bleeding. A falling PCV in the context of ongoing shock strongly suggests significant blood loss. And in that specific scenario, the immediate next step indicated would be a blood transfusion.
Right.
It just underscores how dynamic this all is. It's not a fixed recipe. It's constant assessment and response, adapting the plan based on how the patient's actually doing, minute by minute sometimes.
Which brings us squarely to blood products. When do they actually pull the trigger on transfusions? The sources seem very specific about the indications, not just giving blood products routinely.
Extremely specific. For packed red blood cells, the main triggers are evidence of significant blood loss, clinically estimated at 10% or more of total blood volume. They're also used for shock that just isn't responding to fluid resuscitation alone, what we call refractory shock. Or, interestingly, if a patient is showing signs of fluid overload, but is also significantly anemic, the goal is always restoring the blood's ability to carry oxygen.
Okay, that makes sense for red cells. What about platelets? There's often talk about low platelets in dengue.
Yes, but transfusion isn't automatic just because the count is low. The indications are quite narrow. Platelets are generally considered for patients in prolonged shock, or if the platelet count drops to very low levels, typically below 10,000 per cubic millimeter, especially as a preventative measure of prophylaxis if there's a high risk of bleeding, or, of course, if there's already severe active bleeding happening.
And fresh frozen plasma or cryoprecipitate.
Those are reserved for even more specific situations where there's evidence of coagulopathy, meaning the blood isn't clotting properly and the patient is actively bleeding. You need both factors. These strict guidelines are there to make sure these resources, which aren't without risks themselves, are used effectively and only when truly necessary.
It's clear that every step is carefully considered. So let's fast forward. The patient has been through the worst. Maybe they needed fluids, maybe even blood products, but now they're improving. How do doctors decide they're actually ready, truly stable enough to go home? What are those discharge criteria?
Getting this right is just as crucial as the acute management. Discharge too early, and the patient could relapse. The sources list several strict criteria, and importantly, all of them need to be met. First, clinically. No fever for at least 48 hours, and that's without needing paracetamol or anything else to keep the temperature down. Second, there has to be clear overall clinical improvement. That means they're feeling generally much better, their appetite is back, vital signs like heart rate and blood pressure are stable, they're passing adequate amounts of urine, and very importantly, there's no respiratory distress at all.
Okay, so feeling better, no fever. What about the lab tests?
On the lab side, two key things. You need to see an increasing trend in their platelet count. It doesn't have to be back to normal yet, but it needs to be clearly rising, showing the bone marrow is recovering. And their hematocrit, the PCV, must be stable, and stable without them needing any ongoing intravenous fluids. If they still need IV fluids to keep their PCD stable, they're not ready.
That's quite a comprehensive checklist.
It is, and it has to be. It reflects that meticulous, evidence-based approach needed for a disease that can be so unpredictable. It ensures the patient is genuinely on the path to recovery before leaving the safety net of the hospital.
So, stepping back from all the clinical details, what does this whole deep dive into dengue really tell us? For you listening, beyond just learning about this one illness, I think it shines a light on the incredible level of precision and constant vigilance that goes into modern medicine. From spotting those first subtle symptoms that might make you suspicious through the really...
I agree completely. The sheer meticulousness of it all, Thinking about those precise fluid rates, how they're capered down hour by hour, the very specific triggers for when you use blood versus platelets versus plasma, it really drives home how something that starts as just a fever can suddenly demand these incredibly complex life-saving interventions. It's like watching this intricate clinical choreography unfold, all designed to counter the effects of the virus and support the body's recovery. And it does make you wonder, doesn't it? How many other common diseases out there have these kinds of critical detailed protocols running beneath the surface? Protocols that make a life or death difference every day, often completely invisible to those of us outside the medical world.